Doctor warns, the 5 medical checkups I would never get after age 60. It might come as a profound surprise, perhaps even a shocking revelation, to learn that a staggering proportion, exceeding 90% of otherwise healthy adults aged 75 and older who undergo a comprehensive full-body scan will invariably receive news of an abnormal finding. What truly underscores the gravity of this statistic is the subsequent, often overlooked reality. In the vast majority of these instances, the so-called abnormality detected is, in fact, entirely benign, utterly harmless, and would, under no circumstances, have ever manifested into a discernible health problem or symptom throughout their remaining lifespan. Yet, the cascade of events that typically unfolds after such a discovery is anything but benign. It ushers in a period of intense anxiety, necessitates further diagnostic investigations, frequently leads to invasive biopsies, and, in some particularly unfortunate cases, culminates in surgical interventions, all of which are undertaken to address conditions that were never destined to impact the individual's health or well-being. As Dr. Robert Harrison, drawing upon his extensive years of medical practice, can attest, this disconcerting scenario has played out with alarming frequency in his clinical experience, witnessing firsthand the unintended consequences of intentioned, yet ultimately misdirected medical scrutiny. Today, Dr. Harrison endeavors to illuminate 5 prevalent medical screenings that, particularly for individuals advancing beyond the age of 70, and indeed warranting consideration even from age 60 as a precursor to these later risks, regrettably tend to precipitate more harm than any conceivable benefit. This discourse is not intended to dissuade anyone from seeking necessary health care. Rather, it is a clarion call for a more judicious, intelligent, and personalized approach to health management as one ages. Therefore, if you are an individual over 70, or if a beloved family member or friend falls into this demographic, it is imperative to remain attentive, as the insights about to be shared possess the potential to avert entirely gratuitous medical procedures, mitigate the risk of serious iatrogenic complications, and significantly alleviate an immense burden of undue worry and emotional distress. Before delving into the specifics of each screening, Dr. Harrison wishes to articulate with unequivocal clarity that he is in no way advocating for the wholesale avoidance of medical care, nor is he suggesting that these particular tests are perpetually inappropriate. His central assertion is that the fundamental calculus of medical benefit versus risk undergoes a profound transformation with the natural progression of aging. What might constitute a beneficial intervention for a 50-year-old could paradoxically prove detrimental to an 80-year-old. Medical screening, by its very essence, is an intricate balancing act between potential advantages and inherent hazards, and this delicate equilibrium demonstrably shifts as we accrue more years. Every diagnostic test that will be discussed herein possesses a legitimate and valuable place within the broader spectrum of medical practice. Dr. Harrison himself has, on numerous occasions, prescribed these very tests when the clinical context unequivocally warranted their application. However, the indiscriminate, routine, and automatic ordering of these screenings, solely predicated upon the attainment of a certain chronological age, is extraordinarily commonplace as the human body ages, akin to the emergence of wrinkles on the skin or the silvering of hair, representing entirely normal physiological manifestations of the aging process within our internal organs. Yet, once these incidental findings are brought to light, the psychological and medical imperative to unfind them becomes impossible. Suddenly, an individual is burdened with the label of possessing an abnormality, and their treating physician, driven by a legitimate sense of professional obligation and medico-legal considerations, feels compelled to pursue further diagnostic avenues. This often translates into the scheduling of additional follow-up scans a few months hence, or, more invasively, a biopsy, a procedure that inherently carries its own spectrum of risks, including but not limited to hemorrhage, infection, or damage to surrounding tissues. In the most extreme instances, this diagnostic cascade can regrettably culminate in entirely unnecessary surgical interventions or other treatments for conditions that, quite literally, would never have caused any distress or posed any threat to the patient's health. This entire sequence of medical interventions, from initial detection to potential treatment, frequently originates from a single scan that was, from a strictly medical necessity standpoint, never warranted in the first place. Moreover, if the whole-body scan employed happens to be a CT scan rather than an MRI, an additional and significant concern emerges: exposure to ionizing radiation. A single, full-body CT scan can impart a radiation dose equivalent to several hundred conventional chest X-rays. While the statistically quantifiable risk of developing cancer from one such isolated scan is acknowledged to be small, it is unequivocally not zero. The crucial question then becomes, why subject oneself to such an exposure risk in the absence of a clearly articulated and evidence-based medical benefit? The superior alternative, in Dr. Harrison's expert opinion, is a comprehensive geriatric assessment. This is not a superficial, perfunctory examination. Rather, it represents a meticulously thorough and holistic evaluation specifically tailored to ascertain what genuinely contributes to optimal health and sustained quality of life at an advanced age. Such an assessment typically encompasses a detailed evaluation of functional status, objectively measuring parameters such as balance, grip strength, and gait speed. Simple, yet profoundly predictive metrics of overall health that often yield far more relevant information than any sophisticated imaging scan. It also involves an exhaustive review of all current medications, recognizing that older adults frequently navigate complex polypharmacy regimens, often taking 10 or more different pharmacological agents, and the insidious side effects of these medications are all too frequently misattributed to new and emergent medical problems. Furthermore, a comprehensive geriatric assessment places significant emphasis on fundamental lifestyle factors, including dietary habits, sleep hygiene, regular physical activity, and the crucial importance of robust social connections. These truly represent the bedrock foundations of enduring health and vitality. Ultimately, a comprehensive assessment furnishes the individual with actionable, personalized information, empowering them to make informed choices that genuinely promote sustained health and independence, whereas a whole-body scan, by contrast, frequently serves only to engender anxiety and initiate an unproductive, often harmful, cascade of further superfluous testing. Moving on to the second common screening that warrants careful reconsideration: brain MRI for mild memory lapses. This scenario is remarkably prevalent. An individual over the age of 70 begins to experience minor cognitive aberrations, such as misplacing their keys or momentarily struggling to recall an actor's name. Understandably, family members become concerned and, driven by an admirable desire to rule out debilitating conditions such as Alzheimer's disease, insist upon a brain scan. While the underlying intention is undoubtedly benevolent, the resultant outcome is, more often than not, fraught with complications. Epidemiological research unequivocally demonstrates that a striking 94% of individuals over the age of 75 who undergo a brain MRI will exhibit some form of abnormal finding. Pause for a moment to fully assimilate that figure: 94%. These findings might include relatively minor observations, such as mild brain atrophy, which, in simple terms, denotes a slight and entirely normal reduction in brain volume, commensurate with the aging process. Or they might identify white matter lesions, tiny, often punctate spots observed on the brain parenchyma that, to the untrained eye, can appear disconcerting, yet are detected in over half of all elderly individuals and typically signify nothing more sinister than the cumulative effects of years of subtly elevated blood pressure that may not have been perfectly controlled. The inherent dilemma arises when a 78-year-old patient receives a scan report detailing cerebral atrophy and white matter disease. Such terminology, stripped of its clinical context, sounds profoundly terrifying. While a knowledgeable physician recognizes that such a report is essentially describing a brain that entirely correlates with the chronological age of a 78-year-old person to the patient and their family, it can be misconstrued as an ominous pronouncement, tantamount to a diagnosis of impending or nascent dementia. This artificially induced fear can have transformative and profoundly negative consequences. Individuals may begin to harbor significant self-doubt regarding their cognitive capabilities, leading to social withdrawal, a disengagement from previously enjoyed activities, and a precipitous erosion of confidence in their own mental faculties. All of this distress is generated solely by imaging findings that bear little to no direct correlation with their actual day-to-day cognitive function. Crucially, these subtle imaging findings do not alter the fundamental treatment approach for typical age-related mild memory complaints. There exists no pharmacological agent capable of reversing the normal structural and functional changes that occur in the aging brain. Consequently, the brain scan fails to provide any tangible therapeutic benefit, serving primarily to amplify anxiety. A far more efficacious and prudent approach involves the utilization of straightforward cognitive testing readily administered within the doctor's office. Standardized instruments such as the Mini Mental State Examination, MMSE, or the Montreal Cognitive Assessment, MOCA, can typically be completed within 10 to 15 minutes. These tests are specifically designed to directly assess how the brain is functioning, rather than merely depicting its structural appearance on an imaging study. If the results of such cognitive testing fall within the normal range, both the patient and their family can be appropriately reassured. Conversely, if the tests indicate potential cognitive deficits, the subsequent step involves a systematic investigation into potential reversible causes, of which there are numerous. Vitamin B12 deficiency, for instance, is remarkably common in older adults and is thankfully straightforward to diagnose and rectify. Thyroid gland dysfunction can manifest as symptoms resembling brain fog. Depression, particularly in older individuals, frequently presents with memory complaints rather than overt sadness. Undiagnosed sleep apnea can lead to chronic nocturnal cerebral hypoxia, severely impairing memory consolidation and retrieval. Furthermore, many commonly prescribed medications, most notably sleeping aids and anxiolytics, can significantly impair cognitive clarity and memory. All of these potential reversible etiologies should be thoroughly investigated and addressed before any consideration is given to ordering an expensive and potentially anxiety-provoking brain scan. Should cognitive testing reveal a discernible and progressive decline over time, and all other reversible factors have been systematically excluded, then, and only then, might advanced neuroimaging be warranted as a component of a truly comprehensive diagnostic evaluation. However, for the commonplace, occasional forgetfulness that characterizes normal aging, a brain scan is decidedly not the appropriate initial diagnostic response. The third screening on our list that warrants meticulous scrutiny is routine stress tests for the heart. This particular recommendation often elicits a sense of surprise from patients, as the conventional wisdom suggests that understanding the condition of one's heart is invariably beneficial. However, the inherent challenge with stress tests when applied to asymptomatic older adults is their remarkably elevated rate of false positives. This means that the test results frequently indicate the presence of a cardiac problem when, in actuality, no such problem exists. Why does this phenomenon occur with such frequency. As the human body ages, the heart and its intricate vascular network undergo various physiological and structural alterations that can profoundly influence the outcomes of a stress test, without necessarily signifying the presence of a dangerous coronary artery blockage. Conditions such as protracted periods of hypertension over many years, a thickening of the heart muscle, left ventricular hypertrophy, or subtle electrical conduction abnormalities within the heart can all contribute to abnormal stress test results, even when the coronary arteries themselves are entirely patent and free of significant occlusive disease. So, what are the ramifications when an individual receives a false positive stress test result? The patient is then typically referred for a battery of additional, more invasive investigations. This frequently entails a cardiac catheterization, a procedure during which a slender, flexible tube, catheter, is meticulously threaded through the arteries, ultimately reaching the heart. This is unequivocally an invasive medical procedure and, as such, carries a distinct array of inherent risks, including bleeding at the access site, potential infection, damage to the arterial wall, renal impairment induced by the contrast dye, and, in rare instances, even stroke. In a significant number of cases following such a procedure, the catheterization ultimately reveals that the coronary arteries are, in fact, perfectly healthy, thereby confirming that the initial stress test result was erroneous. Yet, the patient has already endured an entirely unnecessary invasive procedure, exposing themselves to a spectrum of avoidable risks. Even more concerning, albeit rare, is the possibility that the stress test itself can inadvertently trigger serious cardiac events, such as dangerous arrhythmias or even an acute myocardial infarction, heart attack, in susceptible individuals. For a patient who presents with classical symptoms such as chest pain upon exertion, angina pectoris, a stress test is an entirely logical and medically appropriate diagnostic tool, as there is a clear imperative to ascertain the underlying pathology. However, for an asymptomatic individual who is capable of climbing multiple flights of stairs, walking briskly, or engaging in other physical activities without experiencing any untoward symptoms, they are in essence performing a stress test successfully on a daily basis. Their routine daily activities are already furnishing valuable information, indicating that their cardiac function is robust and efficient. If the objective is to assess cardiac risk without the attendant problems and risks associated with a traditional stress test, a superior alternative exists: coronary artery calcium, CAC, scoring. This is a rapid, low-radiation computed tomography, CT, scan specifically designed to quantify the amount of calcified atherosclerotic plaque present within the coronary arteries. A KC score of 0 is a powerful predictor of an exceptionally low risk of experiencing a heart attack in the ensuing years. Conversely, a significantly elevated score provides crucial prognostic information, signaling the imperative to adopt aggressive preventive strategies, which may include pharmacotherapy and intensive lifestyle modifications. This method is highly informative, guiding appropriate preventive measures without initiating the problematic cascade of invasive and potentially harmful interventions that can frequently ensue from a false positive stress test. The fourth screening protocol under scrutiny is colonoscopy after the age of 75 to 80. It is imperative to preface this discussion by reiterating Dr. Harrison's unequivocal stance. Colonoscopy is an outstanding, life-saving screening tool. He strongly advocates for its initiation around the age of 45, as it demonstrably saves lives by facilitating the early identification and removal of precancerous polyps. The principal concern in this context pertains to the continuation of routine colonoscopic screening into advanced old age, particularly when previous screenings have consistently yielded normal results and the individual remains entirely asymptomatic. The rationale underpinning this caution is multifactorial. The primary benefit derived from colonoscopy lies in its capacity to prevent the development of colorectal cancer that would typically manifest 5 to 10 years in the future. However, if an individual's life expectancy is realistically estimated to be less than 10 years, whether due to advanced chronological age or the presence of significant comorbid health conditions, the likelihood of accruing a tangible benefit from further screening diminishes considerably. Concurrently, the inherent risks associated with colonoscopy demonstrably escalate with advancing age. The bowel preparation regimen alone, which necessitates the consumption of substantial volumes of potent laxatives, can pose serious hazards for older adults, including severe dehydration and dangerous electrolyte imbalances. For individuals with pre-existing conditions such as chronic kidney disease or congestive heart failure, this preparatory phase can critically exacerbate their underlying conditions, precipitating serious complications. Furthermore, the sedation agents routinely employed during the procedure carry a heightened risk profile in older adults, potentially leading to prolonged confusion, respiratory compromise, and clinically significant drops in blood pressure. Beyond these considerations, there is the ever-present, albeit rare, risk of colonic perforation, a tear in the wall of the colon. While the overall incidence of perforation is approximately 4 per 10,000 colonoscopies across all age groups, this risk is notably elevated in individuals over 75, and particularly pronounced in those beyond 80 years of age. The colon wall naturally undergoes thinning with age, rendering it more susceptible to such iatrogenic injuries. A colonic perforation constitutes a surgical emergency, frequently necessitating major abdominal surgery, which, in some instances, may unfortunately result in the creation of a temporary or permanent colostomy bag. For an 80-year-old, such a profound and invasive surgical intervention can tragically mark the definitive end of independent living. Major medical guidelines universally acknowledge this shifting balance of risks and benefits. For example, the U.S. Preventive Services Task Force, USPSTF, recommends that screening decisions for individuals between the ages of 76 and 85 be made on an individualized basis, meticulously weighing the patient's overall health status and their prior screening history. Crucially, they explicitly recommend against routine screening after the age of 85. This revised guidance does not imply a disregard for colonic health after 75. Rather, it signifies a judicious shift from routine screening to vigilant surveillance. Patients must be educated about and remain attuned to the pertinent warning signs, reporting them immediately to their healthcare provider. These include persistent alterations in bowel habits, the presence of blood in the stool, whether visible or occult, unexplained and involuntary weight loss, newly diagnosed anemia, and persistent abdominal discomfort. Should any of these symptoms manifest, chronological age becomes irrelevant, and a thorough medical investigation is unequivocally warranted. Moreover, primary prevention remains paramount. A diet rich in dietary fiber is an invaluable ally for optimal colon health. The consumption of ample fruits, vegetables, whole grains, beans, and lentils nourishes the beneficial bacterial microbiota within the gut, which in turn produces protective anti-cancer compounds. This dietary approach offers a far safer and more holistic strategy than repeated, potentially risky colonoscopies, providing systemic benefits to the entire body, not merely the colon. Our fifth and final screening that demands meticulous reevaluation is PSA, prostate-specific antigen, testing for prostate cancer in men over the age of 70. This particular screening has been a subject of considerable controversy for many years, and for very compelling reasons. The widespread application of the PSA test has, regrettably, fostered an epidemic of both overdiagnosis and overtreatment of prostate cancer. What renders prostate cancer distinct from many other malignancies is its inherently indolent growth pattern in the vast majority of men, particularly as they age. Post-mortem autopsy studies have astonishingly revealed that up to 80% of men in their 80s, upon examination, exhibit evidence of prostate cancer. However, the critical distinction is that most of these men died with the cancer, not from it. The malignancy simply remained dormant, never progressing to a clinically significant stage or causing any problems throughout their lives. The fundamental flaw of the PSA test lies in its inability to differentiate between these aggressive, life-threatening cancers that necessitate immediate intervention and the ubiquitous, slow-growing, clinically insignificant cancers that will never cause harm. Consequently, the test leads to the detection of a vast number of these indolent cancers, and once an individual receives the daunting diagnosis of cancer, the natural human inclination is to seek and demand treatment. Yet the treatment modalities for prostate cancer are far from inconsequential. Radical prostatectomy, surgical removal of the prostate, carries substantial risks, including permanent urinary incontinence and debilitating erectile dysfunction. Radiation therapy, whether external beam or brachytherapy, often precipitates similar adverse effects in many men, profoundly impacting their quality of life. These significant side effects exert a dramatic and often devastating influence on an individual's physical, psychological, and social well-being. The U.S. Preventive Services Task Force, USPSTF, after conducting an exhaustive review of all available scientific evidence, has unequivocally concluded that for men aged 70 and older, the potential harms associated with routine PSA screening demonstrably outweigh any purported benefits. The probability of discovering a prostate cancer that would genuinely prove fatal within an older man's remaining lifespan is remarkably small. Conversely, the likelihood of overdiagnosis and subsequent exposure to harmful, unnecessary treatment is substantial. The USPSTF estimates that rates of overdiagnosis are more than 15 times higher in men over 85 compared to men in their 50s. What about compelling factors such as a strong family history of prostate cancer or other established risk factors? These considerations are undeniably pertinent and might, in certain circumstances, shift the risk-benefit balance in favor of screening, even beyond the age of 70. However, such decisions should never be automatically implemented. Rather, they must emerge from a deeply informed, shared decision-making process, a candid, comprehensive conversation between the patient and their physician, critically evaluating the genuine statistical probabilities, the authentic risks, and, most importantly, what truly matters to the individual patient in terms of their personal values and health goals. For men who are diagnosed with very low-grade prostate cancer, active surveillance frequently represents the most judicious course of action. This strategy involves carefully monitoring the cancer's progression without immediately initiating aggressive treatment, intervening only if and when it demonstrates definitive signs of becoming more aggressive. Regular PSA measurements, periodic digital rectal examinations, and repeat biopsies, often guided by advanced imaging like multiparametric MRI, serve to keep a vigilant eye on the disease while allowing the patient to circumvent the life-altering side effects of unnecessary treatment for a cancer that, in all likelihood, would never have caused them harm. In summation, we have meticulously reviewed 5 common medical screenings that, particularly for individuals advancing beyond the age of 70, frequently create more problems than they purport to solve. These include whole body scans that invariably uncover harmless abnormalities, thereby initiating a problematic cascade of superfluous and anxiety-provoking diagnostic testing, brain MRIs performed for mild, age-related memory concerns that primarily serve to generate undue anxiety without furnishing genuinely useful clinical information, routine cardiac stress tests that exhibit a regrettably high rate of false positives in older adults, leading to invasive follow-up procedures, colonoscopies conducted after the age of 75 or 80, especially when prior screenings have been consistently normal, exposing frail individuals to increased risks with diminishing returns, and PSA testing in men over 70, which demonstrably contributes to the twin scourges of overdiagnosis and overtreatment of slow-growing, clinically insignificant prostate cancers. What overarching theme inextricably links all of these screening modalities? They are all paradigmatic examples of proactively seeking out problems in individuals who are entirely asymptomatic. And as we gracefully navigate the later stages of life, this particular brand of diagnostic zealousness becomes progressively less likely to confer genuine benefit and increasingly likely to inflict harm. Dr. Harrison wishes to emphatically underscore once more that this comprehensive discussion is not an argument for eschewing all medical care. Rather, it is a passionate plea for smart, judicious, and patient-centered medical care, a paradigm shift towards focusing intently on interventions and strategies that demonstrably improve actual health outcomes and enhance the overall quality of life. A meticulously conducted comprehensive geriatric assessment will consistently prove superior to a whole-body scan in providing actionable, relevant information. Brief, targeted cognitive testing far surpasses a brain MRI in its utility for evaluating mild forgetfulness. Vigilant awareness of pertinent warning signs combined with a steadfast commitment to a healthy lifestyle offers greater benefit than routine colonoscopies for the very elderly. And above all, honest, empathetic conversations between patients and their healthcare providers, grounded in shared goals and personal values, will always trump the indiscriminate automatic ordering of PSA testing. The overarching objective of healthcare for individuals beyond the age of 70 should extend far beyond the mere detection of every conceivable anatomical abnormality. Its true purpose must be the steadfast preservation of function, the promotion of independence, and the safeguarding of an enriching quality of life. Indeed, sometimes the most profoundly therapeutic action a physician can undertake is precisely not to order an additional test, but rather to dedicate time to truly sit with a patient, to actively listen to their concerns, to understand their priorities, and to collaboratively devise strategies that empower them to remain active, socially connected, and deeply engaged with life itself. If there is a singular, indelible message that Dr. Harrison hopes you will internalize from this extensive discussion, it is this: you, as a patient, possess an inherent and inalienable right to ask incisive questions. When your physician recommends a particular test, you are entirely justified in inquiring about the fundamental rationale. What specific information do we hope to gain from this result? How will this information alter our current management plan or influence future decisions? What are the potential risks, both immediate and long-term, associated with undergoing this test? And, crucially, what are the potential consequences or alternatives if I choose not to proceed with this test? These are not confrontational inquiries. Rather, they are the hallmarks of an informed, empowered patient who is actively engaged in the stewardship of their own health. The therapeutic relationship between patient and physician should, at its core, be a collaborative partnership. You, the patient, possess an unparalleled understanding of your own body, your personal values, and what holds the utmost significance for your well-being. Your doctor, in turn, brings invaluable medical expertise and knowledge. Together, in synergistic collaboration, you can collectively forge decisions that are holistically appropriate and genuinely meaningful for you as a unique individual, rather than merely adhering to the dictates of a generic guideline or a statistical probability. Therefore, the next time a medical professional suggests one of these specific screenings, pause, reflect deeply, articulate your questions, and ultimately make an informed decision that resonates with your personal circumstances and aspirations. For the ultimate aim of healthcare is not merely to prolong existence, but to enable us to live well, to live with dignity, to maintain cherished independence, and to experience enduring joy. And paradoxically, sometimes the most effective strategy to protect these invaluable aspects of life is to courageously and thoughtfully decline a medical test that is simply not necessary. If you have found this extensive information valuable and insightful, Dr. Harrison sincerely encourages you to disseminate it widely to others within your social circle who might similarly benefit from these critical perspectives. Furthermore, he invites you to subscribe to the channel for a continuous stream of evidence-based practical advice on maintaining optimal health as we age. Finally, he genuinely welcomes your thoughtful comments below. Have you ever felt undue pressure to undergo a medical test about which you harbored reservations? If so, how did you navigate that situation? Your personal experiences and insights are deeply valued and contribute significantly to this vital conversation. Until the next insightful discussion, may you remain well, and always remember that smart healthcare is fundamentally about discerning precisely when to embrace a medical intervention and, equally importantly, when to judiciously decline